It's good to see you.
Okay, good to see.
We're now live. Hello, and thanks to everybody who is joining us. I guess I should give a little bit of background, since some people are just like seeing this on their recommended page on YouTube and are like, "Wait, what's going on?" I am joined today. I'm John Green of the Vlog Brothers, and I'm joined today by Dr. Bailor Barrie, who's the founder of Well Body Clinic in Sierra Leone, and a hugely important figure in the healthcare system in Sierra Leone and for healthcare equity globally. And we're going to talk about some about the project that our community is helping to fund through for the Maternal Center of Excellence at Kono in Kono District in Sierra Leone, and a little bit about Dr. Barrie. Hi, Dr. Barrie. How are you?
Hi, John. Good.
It's very nice to see you. I wonder if you could, like, just for the background of our viewers, give us a little bit of an introduction to yourself and your life and how you came to be a physician and came to do this work in particular.
Yeah, I'm Dr. Mohamed Bailor. I'm a Sierra Leonean, born and grew up in Sierra Leone. I grew up in a very poor family, a family that made less than $1 a day. I wanted to become a doctor at the age of 6, actually, when one of my neighbors, a nurse that sees patients, I admired him so much that I wanted to be like him. But I never realized how difficult it is to become a doctor in Sierra Leone, because then there was no medical school in the country. And if you want to be a doctor, you either have to travel out of the country, or you have the money, your family have the money to send you out of the country, or you have the political contact or connection to live, neither of which I have. But in 1988, they opened the medical school in Sierra Leone, and so professors from the medical school went to the high school. I was in high school then, went to different high schools and was talking about the medical school. So that ignited my hopes, and like, oh well, I'll become a doctor. But when they left, they posted a flyer on the notice board. I went there and looked at the fees, and that hope dropped. I said, oh my God, my family cannot afford that. But then there was a scholarship in the country that the best 2 students that took the A levels and got the best grades in the country, the best 2 students will be given a scholarship to go to any university in the country. So I studied hard, and fortunately I was the second best student in the country, and I got a scholarship to go to the medical school. And during medical school, I struggled a lot, including handwriting textbooks, walking 40 miles back and forth from school. But I sailed through and become a doctor. And then during those periods that I was working to college and back, I was thinking about poverty. I was thinking about kids that I met on the road going to school, working without sleepers and whatever. And I thought about like what's going on in this country. And I had this vision of like trying to help. So when I graduated, while all my colleagues left the country to Europe and America, I stayed back, and I was working in the government hospital. But one incident actually struck me that made me change my passion. I was working in the pediatric hospital. So there one day they brought a kid to me, but in the healthcare system in Sierra Leone is actually many people have to pay out of pocket. So the mother had paid the consultation fee, paid for labs and everything. I prescribed for her. The child had malaria. I prescribed the drugs for her. She could not buy the drugs. So she went with the kid home. For 3 days, she was looking for money to buy the drugs, and then the kid progressed to severe malaria. So they brought the kid back, this time convulsing. And I recognized the mother and asked her, like, oh, what's happened? Why didn't you buy the medication? Or she said you didn't have the money. That really gets onto me, and I was like, oh my God, if I hadn't taken the consultation fee from this small woman, she would have gotten the money to buy the medication. So I was really frustrated. I regretted being a doctor. I was frustrated. But then I took a job with a Catholic hospital in the north, where actually in Putloko district, Lonsar. And there I started like educating women. When they come, before I start seeing them, I'll give some talks about them, about like, traditional practices and like things that they should not do and stuff. And then it became, and it impacted them, and they like stopped doing that, and that really moved me towards like wanting to do public health and wanting to do global health. And then I met an American doctor who came to Sierra Leone on a global health fellowship, and he had read about health and poverty a lot, but I lived health and poverty. I lived the life. So we started talking and connected, and then decided to found Well Body Alliance. But when we founded Well Body Alliance, I told him like, I mean, I'm from the north, I'm from Bombali district, but like I prefer we do a tour across the country, because like we wanted to start Well Body for amputated civilians during the war. And so we were told by one of them that there are a lot of them across the country. So we took a tour across the country. And then when we get to Kono, I was shocked, because Kono was the district that everyone in the country admires, the Diamond Rich district. And the people have all the beautiful homes in Freetown, in McKinney, where I grew up, were built from people from Kono. So I thought Kono would be a paradise. So when I went to Kono, I saw the aftermath of the war. Like, you can see the burnt homes. You can see the aftermath of the war. You can see the streets are terrible and homes are terrible. And then I decided that we should start in Kono. So, and then when we went to the hospital, there was nothing in the hospital. No beds. There are few beds. Patients were spreading mats on the floor and lying down, and it was terrible. So we started working in Kono to serve the amputees. But in 3 months when we went there, I realized how dysfunctional and inadequate the healthcare in Kono was. So we opened the clinic to the general public, and we started developing the clinic slowly. And here we are. And in 2014, we partnered with Partners in Health that came, and we joined forces together and developed the clinic and the government hospital. And now it's like the best hospital in the country.
Yeah, I mean, Well Body Clinic is, at least from what I saw, overwhelmingly the best healthcare clinic in the country, and in a country where 1 in 20 women can expect to die in pregnancy or childbirth, Well Body has, delivered. I mean, correct me if I'm wrong about this, but has delivered hundreds and hundreds of babies and hasn't seen a maternal death in more than 4 years, right?
Yeah, because we opened it in 2015, and to this point, we've not seen any maternal death. And it tells you about how quality of care, how you can avert maternal death through developing a robust care. And like, actually, that maternal center came about when we were doing a program called Maternal and Child Health Reduction Program, where we were training traditional birth attendants to be community health workers, to targeting women in the community and bringing them to the facilities. And then one day, one woman that had three stillbirths was pregnant, and we met her in the community. She's been in labor for 3 days, and like I went and examined her and thought like she had a cephalopelvic disproportion, where the baby is bigger than the path out. So we referred her to KGH. So I accompanied her to KGH. I told the nurses that this woman needs this baby. This woman had gotten three stillbirths, and this baby is precious, and the baby is alive. Please let the baby live. So I left and went. I was doing this education program in the community, and then they called me that woman has delivered a live baby, and everybody was happy. And then immediately after I finished the program, I ran to the hospital, and then I entered the room. The woman sit up and said, "Oh, thank you, doctor. I had my baby cry and whatever." Then I turned to the nurses and asked, like, "Where is the baby?" So they showed me the baby lying in a cot. I went there to see the baby dead. So that really like struck me. That really made me, I was so like devastated, and I was thinking about how maternal and child health should be fully integrated. There should be somebody taking care of the baby where others are taking care of the mother. And so we decided to build our maternal and child health maternal center in KGH for 2 things. One, to integrate traditional traditional birth attendants in healthcare so that they can provide the comfort that they provide when women deliver in their homes, and also to kind of like create a model of a room and a quality, high quality maternal and child health program that can serve as a center of excellence in Kono. And so we built the clinic, and then boom, partners in health joined us after we finished building it. Then we merged with partners in health, and we opened it and started running it with all programs integrated within the maternal and center, where we also added a birth waiting home, where we built about 4 homes that women could come and wait when they are high risk, when they have high risk pregnancy, so they can be closer to the labor to the maternal center when they come into labor. And so with all those components, we found out that women are not brought to well body late, because we will identify with high risk pregnancy and bring them early, so they stay in the birth waiting home. When they come into labor, it's just walk into the maternal center. And also we're doing family planning there. We're doing a very good prenatal care and nutrition, and like with all those programs integrated, we've seen a huge success in maternal and child health in well body.
Yeah, and I saw it in PIH's annual report that they just released. That, by the way, everybody can read it, pihsierraleone.org. I know that annual reports are usually not like the most fun reading, but this is a really nice annual report. It has a lot of white space, a lot of pictures. I mean, I ate it up. But just in the last year at KGH, neonatal mortality has dropped by almost half. Which is incredible because there's a new neonatal ward that's just for babies and has been hugely successful. But what you and your colleagues have accomplished at Wellbody Clinic it's one of the most amazing things I've ever seen in my life, especially in contrast to other primary healthcare clinics in the district, where they're still so under-resourced and so deeply impoverished. I know last year when we were in Kono together, we went to a healthcare clinic in is it Combiende?
Combiende,
yeah.
Combiende.
And it was just in stark contrast to Wellbody, hugely inadequate for the needs of the community, and as a result, almost no patients.
Yeah. So what I've seen in my experience is that what patients really need is quality healthcare. And like when you provide quality, patients will come, even if you ask them to pay. But I know poor people will not access it because of the transport or whatever, but they will be willing to pay for high quality care, and they will not be willing to pay for care that is not high quality. And so what you'll see in remote communities in Kono is people relying on traditional birth attendants, traditional healers, informal healthcare, because there's the alternative is not good. And so what PIH is striving to do across the world is to bring the benefit of Western medicine into the most rural and poorest communities in the world. And like the care that is provided in Boston, in a hospital in Boston, should also be the same care that is provided for the poorest person in Kono. So it's like, and that's what the vision of this maternal center of excellence is like, to provide a high quality care that everybody in the world require, everybody in the world desire, is what we want to do. We don't want to fall short. We don't want to give like poor people different kind of healthcare and rich people different kind of healthcare. We want to give everyone the same healthcare that they deserve, that they needed. And so, for example, the healthcare system in Kono is being like affected by the long history of one-time investments. Like when we went to Kumbayende, you see a radio there that was not functioning. You can see like a piece of equipment that is standing there gathering dust that is not functional, because the donor just thought about like, okay, they need this equipment, I'll buy them the equipment and give them, but not thinking about how can they use it, how can they sustain the use of this equipment, how can they use it for a long time, how can it impact the community, rather than just like bringing the equipment, and when the equipment broke, nobody is there to fix it, and the community don't have the money to fix it. So it becomes like a furniture, and that's what you see across the country, across the whole country of Sierra Leone. You see donors come with piece of equipment, come up with programs that last for 1 or 2 years, and then they're gone. And like when anything breaks or whatever, there is no continuity, no continuity in the program. And we have to realize that Sierra Leone, in as much as we're spending about 12% of our GDP in health in Sierra Leone, but what's the GDP? That's the question that we need to ask. What's the GDP? So if my GDP is like $5,000 and I'm spending 12% of that, is nothing compared to like a country with a high GDP. If they spend 5%, even what they're spending is high. So, and Sierra Leone suffers from this, and they think Sierra Leone. No, when you compare Sierra Leone to other West African countries, you find out that Sierra Leone is doing well. They're trying to spend a lot in healthcare, but the GDP is small. Sierra Leone is a very poor country, and so even though they put a lot of money in health, there's very small little money that is being funneled to healthcare, and so and we're still stuck with this colonial system of like budget-based healthcare. Each district have a budget, a line-based budget, and like strict budget that you are not flexible to spend where there is need or whatever. All that impacts, and all that is developed by the colonial masters, and like so, all that combined increases the burden of disease, and so like the healthcare system is mostly high burden on the population, on the patients. Most people have to pay out of pocket for their healthcare, and like and the risk pool is within their family. And you imagine a poor man might have been born by a poor man and might have a poor family, and like so that risk pool, it's like within that same poor family, within that same poor family with the same health conditions, with the same, so it's like all making people having catastrophic health
Yeah, I
issues.
think this is a really important thing to understand. One, that these conditions are not natural or inevitable, that they arose from historical forces. The force initially that Sierra Leone was the epicenter of the West African transatlantic slave trade, and then that Sierra Leone was impoverished by a very long period of colonialism, and just to give people a little bit of context, like one statistic I often cite is that in 1950, Sierra Leone, like average life expectancy in Sierra Leone was probably lower than it had been 500 years ago, or even 3 or 4,000 years ago. Such was the way that colonialism functioned in Sierra Leone. And then the second thing, to your point about how much money you can spend on a healthcare system, Sierra Leone's per capita GDP is, I think, $550. And so if you spend 12% of the GDP on healthcare, which is more than what France spends, more than what Australia spends, you spend about $63 per person per year on healthcare. That is, you cannot build a good functioning healthcare system with $63 per person per year to spend on healthcare. It just is impossible. And so the Sierra Leone is a country that has gotten stuck in this vicious cycle of starting out impoverished and never having enough money, never having enough resources to invest into the healthcare system. And the hope is that if the world pays attention to that problem, it can be fixed. We know it can be fixed because we've seen huge progress in Sierra Leone. We've seen tremendous progress in other countries as well. Like we know this is not natural. We know this is not inevitable, and we know that it can get better because it has gotten better. It just the pace of change needs to accelerate because there is so much inequity in terms of access to healthcare.
Yeah, absolutely. And I like what you said, like the health expenditure per capita is about $60 per capita, which is almost nothing
Yeah.
in for healthcare, with the history of like lack of investment during colonialism. Sierra Leone is a country with a lot of minerals, and during colonialism, colonial countries, when they come to a country, if this country has minerals or whatever, they'll focus on the extraction, on the extraction, and not building systems to get taxes. So they have two ways. One, in countries where they think there is no minerals or whatever to mine, they will invest on the humans so that they can tax them to get money. And like in countries where there's minerals, they will not focus on building the capacity of the people or whatever. They will rather just extract. And so that's where Sierra Leone falls. It's like just all these colonial masters were just extracting from the country, and a long history of extractive industry, lack of building institutions to empower the country to grow, and and then now coming again and doing this short-term commitment programs that are 2-3 years long, and like they just come, invest, and go, and all that culminated to the country having this vicious circle. Like the country doesn't have a lot, and like these people come, they pretend to help, but they just make it worse, and then it's difficult to pick up from that. And I think I pity the country, and also that the narrative that is around the world. Oh, Sierra Leone Sierra Leone is what it is because of the corruption. You kidding me? That to me is very ridiculous. I mean, because like all countries are corrupt, but like in a country with nothing and added to a little bit of corruption, they need to get worse as compared to like America. America is also corrupt. England is also corrupt. All those countries are corrupt, but nobody talks about their corruption. They talk about the corruption of Sierra Leone that is really very poor, and the government don't even have money to invest in healthcare, to invest in school, to invest in agriculture, and the thing is because of corruption. That really makes me sad when I hear people saying that.
Yeah, I think a lot of times it's used as an excuse by people living in rich nations not to look hard and at the problems of impoverished countries, and not to kind of, it's used as a way of not having to really grapple with the complexities and difficulties of living in a world where every time we turn on our smartphones, we are using resources from mined by Congolese people that did almost nothing to lessen the poverty of those people, or indeed like the poverty of the nation where they live. And I think corruption is corruption is a problem, and it is a problem in many countries around the world. It's a problem in the United States. But to your point, nobody ever asks me, why do you work with PBS, which is part of the corrupt American government? Like, Crash Course, some of our educational media projects in the past, we've worked with PBS, which is part of the US. Nobody ever asks somebody who works with the BBC, why do you work with the BBC, which is part of a corrupt government? And I do think that we hold these things to a very different standard, which again is not to say that corruption is not a problem. It's just to say that I don't think it's a good excuse, and I don't think that the people who ultimately I don't think it's the ultimate cause of poverty in poor countries. I mean, I think there's overwhelming evidence that it isn't actually, because sorry, go on.
Is an excuse to stop the conversation of poverty. Like when the country is talking, is a way of stopping the conversation or shutting down the conversation. So you bring corruption as the issue, or that country is corrupt, so we don't have to invest in that country. But like how many money pass through the government? How many monies that are coming to this country pass through the government? how deliberate are they in working with governments and trying to make them stronger and trying to build institutions that make this government stronger? Instead, they put corruption on the face of the conversation so that they can shut down the conversation. So that really makes me really sad and annoyed sometimes when people use that as an excuse to stop a conversation about, when you talk about, we want to solve this problem. There's a problem that needs to be solved, but like you put corruption to stop the conversation. So you don't delve into talking about the problem anymore. Instead, it's just, oh, that country is corrupt, so we don't need to invest there. Or that country is corrupt, you don't need to, if you give this money, it's going to the drains because that country is corrupt.
Yeah.
It's sad.
I want to ask some of the questions that we've had in comments, and so one that's come up several times and that's come up a lot in our discussions around this is how Sierra Leone and the Sierra Leonean healthcare system are responding to the challenges of COVID-19 and what that's been like.
So I would say I really admired the government's response to COVID, and I think it's as a result of what I've been saying, that when you invest for long term, you have the impact. Like, for example, during Ebola, we build structures, and like we were deliberate in building structures and using some of the money to build the structures for times like during COVID. So like there were structures already in place that were easily activated to respond to the COVID outbreak. I would not say there are not some challenges or whatever, but like because of those systems that were created during the Ebola, we were able to activate them quickly and respond quickly to the COVID. And now you can see that Sierra Leone is one of the countries with the lowest confirmed cases in the world, and also like because they activated they closed their border early, they enforced mask wearing, they had a curfew and all those things very early in the game. So like it did not spread much. And initially I thought like, well, we're not testing a lot of people, that's why, or whatever. But I'm currently involved in a research, doing a surveillance for Sierra Leone to see what's the real prevalence of COVID, to see whether they are symptomatic or symptomatic. I think that research will tell us a lot about the COVID outbreak. But like to this point, we're seeing only 440 cases total since the COVID started, which is amazing. It's 74 deaths. It's a lot, but like I think we responded well to the COVID, and currently, even I remember when I went to the US, nobody asked me about a test. Nobody asked me about a test result. I went to the airport and just like they took my passport, stamped it, and I walked away. Whereas when you come to Sierra Leone, there's a system. You have to show that you have a COVID negative. They test you again at the airport. They take your sample and ask you to quarantine until your results come back. It's a system that is helping. So I think COVID, we've tried our best to handle COVID. And now, unfortunately, I was like part of the surveillance team and the lead of the COVID response for partners in health in Sierra Leone, working with the government, building all the strategies and building all those policies. So I think we're doing well.
Yeah, and I also wasn't part of the early response having community health workers get out into communities and talk about how COVID is spread and what we know about it, people who are kind of trusted in their communities, getting into those communities and being able to talk directly with people?
So absolutely. So for Connor, what we did was like we trained about 125 social mobilizers that go house to house, educate people about COVID, screen people, link them to contact tracing. And I was also fortunate to be able to design with the PIH team to design the contact tracing, the contact tracing teams for each district. We train 110 contact tracers. When there is no COVID in the district, they embark on social mobilization, educating the community. These are people from the community that the community know, they trust. We train them to be able to educate the community about COVID and tell them about preventive measures. I think that also a part that plays towards the COVID not spreading the way it spreads in other countries, because there is strong contact tracing, strong surveillance systems in the country right now that is helping a lot.
Another question we've had is about infrastructure in Sierra Leone and in Kono especially. I know that infrastructure, in some ways, we think of infrastructure as being separate from healthcare systems, but this is the wrong way to think about it, because if an ambulance, or if a person cannot get from a clinic to the hospital, that is a healthcare problem. And it may be a transportation systems problem, but it is a healthcare problem, and it ends up resulting in many, many unnecessary deaths. And you've told me stories about women who died in pregnancy, not because what was wrong with them wasn't treatable, but because the motorbike ride to the hospital took too long because the roads weren't good enough. And I wonder if you can talk about what the infrastructure situation is like right now in Kono, and how it's changed or changing.
So I would say it's the road network is really terrible coming from the interior to Koido Hospital. But the government is trying their best. I think the government just approved a budget to build about 7 or 8 feeder roads in Kono. They'll grade them. They're targeting the mining company to help do that. But also, when I started working in Kono, the road from Freetown to Kono would take like 14 hours to get there. And now you see it's paved to Kono. It's great. And so the government is trying to do their best. And it will take time for them to be able to get robust road networks across the country, so that people can get from one place to another. And that's also what's the real problem during Ebola, when there were few treatment centers. You have to travel miles for hours to get a patient to a treatment center, so they will die on route and all those. And it's also a problem right now with maternal and child health. When a woman is pregnant, she's already a high risk, and then you put her in an ambulance traveling for this long distance on a bad road to go to where she can receive care. Before she get there, if she's bleeding, a road that would have taken like 2 hours to get to the hospital will take like 6 to 8 hours, and she's bleeding and all those things. So these are things that even though we're trying to help with the healthcare system, we're trying to build a maternal center of excellence in Koidu, but we're also engaging the government to also help us support by building infrastructure so that people will access the maternal center of excellence easily.
And I know when you first visited Kono, or first came to Kono, when you were starting the Well Body Alliance, and you visited Koidu Government Hospital, you felt like it was just almost not a hospital. It was almost nothing. Now it's very different. And I mean, I've only seen pictures of what it was like during the Ebola crisis, but it was certainly no electricity, no water, very, very limited pharmacy, no climate control in the pharmacy, etc. If you contrast that to now, when there is consistent, I mean, correct me if I'm wrong, but there is consistent electricity, there is clean water, it is a safe place. The ORs for emergency C-sections are at least safe. They're still not where they need to be. But does that make you hopeful, or does it make you all the more frustrated by what hasn't been done yet?
Well, it makes me have a mixed feeling. I'm hopeful, and I'm also kind of frustrated, because I know what I met in Kono when we started working there. I know how the hospital, there's no electricity, no running water. And like, imagine in a hospital, no electricity, no running water. How can you even have a NICU? How can you even have a baby center that requires like 24 hours electricity? You cannot. Even if you want to do it, you cannot without the 24 hours electricity, without the running waters. And so now I'm kind of like hopeful that we're doing our best, but I think the pace is still slow for me. Honestly, I think we can do better. We can do a lot more better to get to the point that we wanted to get, where we want to see like no pregnant woman die from pregnancy in Sierra Leone, and no child dies from nobody dies from preventable deaths in the country. And that frustrates me, because like I feel like still a long way to go. Like for KGH right now is the worst hospital when we started working in Kwedu, and now is the best hospital currently in the country. But even as the best hospital, it doesn't have everything that is required as a hospital. It still lacks a lot of basic things that needed for healthcare, but it's the best hospital. So that really frustrates me. Like, oh, this is the best hospital. Is this all we can offer? And no, we can offer more. And that's why we're striving, we're working hard as partners in health, striving to do much better, trying to raise funds as much as we can so that we can do much better than what we're doing right now. We've taken the hospital from the worst to the best, but there is still a huge gap in, like, for example, there was no NCD clinic in the country, right? We had one in Kono. There's no mental health in Kono. We had now a mental health program, a mental health clinic in Kono. There was like minimal community health workers that I started to make community health worker program in the whole country, and now it's in the whole country. Community health workers are in the whole country, and like all that is a step towards the better, but we need to do more.
Yeah. Yeah, one of the things that really struck me when we visited last year, and when we talked with you, was well, two problems, I guess, and this is something that's come up in comments, which is why I mention it. One, the challenge of training healthcare workers. I mean, your training was so extraordinary, and you had to be so extraordinary to become a doctor. You know, I can't remember if you mentioned this in this conversation, but you had to leave Sierra Leone during the war and find ways to continue training from a refugee camp, and I mean, just huge challenges, having to write out stuff from textbooks by hand, like copying, like it was 1,000 years ago. And that challenge of training healthcare workers remains a really big challenge in Sierra Leone. Like you still can't, I believe you still can't you still can't do the full OBGYN training in country, right? Like, don't you still have to leave for some of the specialty training? There's still, and that's one of the things that the Maternal Center of Excellence is seeking to change, that to make KGH a full teaching hospital that can train OBGYNs, that can train labor and delivery nurses really effectively with the same quality of training that they would get anywhere else. How do you feel like the training is changing or could change when you imagine the future? How is it different from the way that you had to become a doctor?
So I think a lot has changed, because like even when I finished medical school, there is no specialty program. And if you need to be a specialist, you either need to go, you take the primaries from the West African College of Medicine or Physicians or whatever, go to Nigeria or Ghana to become a specialist and come back. And now I think they've accredited surgery, and like they've accredited family medicine in Sierra Leone. Now people can specialize, and also I think they're accrediting OBGYN and pediatrics. by some Sierra Leoneans that came to this that were Sierra Leoneans, and both the wife and the husband are doctors, and they wanted to start like a specialty program in pediatrics and surgery. But like, we need to also build the infrastructure to be able to do that. We need to build the system to be able to do that and do that effectively. It's not about just bringing a specialty program without the components that makes it a good program. And like with the Maternal Center of Excellence, we know even like Kono, because of the development that we did in Kono, Kono is like a rural site for the surgical training program that is sending doctors to Kono for a rural posting, and they learn a lot, and and they admire it a lot. And like, so the goal for this Maternal Center of Excellence is not only to train OBGYNs, nurse, midwives, and all those things. It's also to train managers, health managers, middle managers. Like, we want to see it as a training center for the next generation of healthcare professionals in Sierra Leone, both at the administrative level and at the clinical level. So, because what we are lacking in Sierra Leone is both the clinical and the managerial positions. I mean, you don't have good managers in the hospitals. You don't have good managers in the ministries and all those things. It's like a center that, for example, I'm really my vision for that center, for that maternal center of excellence, is not only to be a center that's trained as OBGYNs and pediatricians and nurse and and midwives and whatever. It's also to train mid-level managers in Kono. And so, and we're striving to do that, and like to be like the hub for not only Sierra Leone, for West Africa, for it to be a West African hub to train high quality obstetrician and gynecologists and midwives, and like also middle managers in healthcare.
We have a related question, and this is a question that I remember I asked you last year, whether you can talk about the phenomenon of brain drain, and when Sierra Leonean healthcare workers, especially when they train internationally, sometimes then stay or go and practice internationally, and what you think the causes of that are and the solutions to it.
So I would like to describe it with the pull and push systems phenomenon, where you have the receiving countries have a lot of resources, have a good standard of care, and have encouragement for doctors when they go there. And also the pull, the push phenomenon is like in the countries in Sierra Leone, where when you're working in Sierra Leone, you're working in a hospital that has nothing. Even though you know what you need to do, but you don't have the resources to do it. You don't have the equipment to do it. You want to prescribe certain medications, you don't have the medications. So the standard of care, the quality of care that you're providing, in as much as you're trained to provide good quality care, you don't have that good quality of care in your surrounding. And so that frustrations will also lead you to want to leave the country. So and so that's why we're seeing a lot of brain drain in the country. Like, for example, if I'm training in the US, I see, even though the healthcare system in the US is not that great, but like it's great for doctors, right? It's great for nurses, it's great for the care provider. So I don't want to come back. And that's why I admire people like Aisha and Vicky that left their practice in the UK and the US and came here to help PIH, right? Because like it's difficult to make that decision to come back when you're in the US. And it's also, for example, when I was trained, all the doctors I graduated with, the class before me, the class after me, the class after that class, everybody left the country. Because England wants doctors, US want doctors, all Europe, developed countries want healthcare providers. So they will accept them, they will go. And then they will leave the country with very minimal healthcare workers. But what we want to do is, like, if we want to make sure that if a clinician works in Kono, he works in the Maternal Center of Excellence, he works at Kwedu Government Hospital, he would think that, okay, I can do what I want to do. Like if I want to save this patient's life, I have the equipment to save them. I have the medications that I will prescribe to save this life. And that frustration is, we take that frustration off of them. I think that will reduce the push, and that could reduce the number of clinicians that leave. And it's not only Kono, but we're trying to make sure that the government replicates the program we're doing in Kono, so that they can do it in at least 3, 4, even at the regional districts, and like encourage more clinicians to stay and work in the country. And I think, honestly, as a clinician, I don't want to leave my country. I want to save. I'm trained to save people, to treat people. I don't want to leave my country, but like the frustration that I face in the workplace makes me want to leave.
Right. The frustration of not being able to do the work that you've been trained to do, of having to, I mean, as you described, to be able to diagnose malaria in a kid and be able to say, this is what you need in order to treat this malaria, but not be able to actually save the kid's life because of the weakness in the system. I was reading, there's a wonderful novel called Whose Names Are Unknown that was written in the Great Depression by a woman named Sonora Babb. And there's this one scene where she writes about a doctor who's treating a malnourished pregnant woman, a woman who's living in poverty as a result of the depression, and so she can't afford food, and she ends up miscarrying. And this is what Sonora Babb wrote about this phenomenon. The doctor felt suddenly impatient, not with the woman before him, but with the whole business of watching people live and die and being able to give them little more than a half measure of help in either. If he questioned this woman about her diet, he knew what he would find out. It was the same with all of them. No use to ask when he could not help. He could give them his time, his knowledge, his skill, but he could not give them what they needed. And I think that's so important to understand, that if you put somebody who's been worked so hard and received so much training and they know what to do, and you put them in a position where they cannot give what the patient needs, it's a horrible position to be put in day after day after day. And I think anybody would feel the push to not be in that situation.
Absolutely, absolutely. When I was a young doctor, when I just graduated, I was working in Freetown. For every morning I wake up, I'm frustrated to go to the hospital, because I know I'll stand there and see a kid gasping. There's no oxygen concentrator, no oxygen to give this child. And I know that if you have just one oxygen concentrator, you will save the life of that kid. You see a kid dying, you know what to do for that kid, but it is not at your reach. You cannot get it, and so it's frustrating. But it takes you the courage. It takes you the courage and wanting to really help your people that makes you stay. I never blame people that leave this country. I never blame them, because like I think it takes a man with the strong courage to stay in Sierra Leone.
Yeah, I can imagine it's challenging. Can you talk a little bit about what you see in the next, our current plan, or when we sat down with John Lasher at PIH Sierra Leone headquarters and talked about a 5-year plan. If we're 1 year into that 5-year plan, what do you think the healthcare system in Kono can look like at the end of that 5 years, in 4 years from now?
So one, I believe that in 5 years would have finished the Maternal Center of Excellence and opened it, and it started operating. And layering to that is the primary care expansion that we're doing right now, which means like we're supporting government clinics that we're trying to replicate the well body clinic, so that those facilities will be able to see patients and care for patients and provide high quality care compared to body. So in 5 years, I want to see that like we're in at least four 4 primary care facilities that are strategically located. We've selected them and we've started working in them. Like Kumbayande, we've already finished the work of the renovation, the structure. Now we're trying to stock the facility with medications and equipment and the lab and everything. And like Swafe, we've also finished it. And like, so in the next 5 years, I want to see a healthcare system in Kono that has the maternal center of excellence, operational and seeing patients and admitting and seeing patients, with 4 facilities and a robust referral system that could bring patients from those facilities when they needed hospitalization or cesarean section to Wellbody to KGH. And like, we're building in those facilities where, like, for Wellbody right now, we have a mental health program there, we have a nutrition program, we have like an NCD in KGH. We want to see that in this facility they can also care for that, so that we can see a reduce in the number of patients coming to Wellbody Alliance. As now we're seeing over 250 patients a day, about more than 300 patients a day. And so we want to see that number drop so that they can go to these other facilities and seek care there and ensure that they're able to receive the quality of care that they would have received at Wellbody Alliance. So in 5 years, I want to see that KGH is well improved and providing quality care with the addition of the maternal center of excellence, with those 4 facilities feeding KGH as a pilot. And then talking about the 10 years, I want to see Kono with all the CHCs in Kono fully functional and robust like Wellbody, and I think the healthcare system and driving all those health indicators down.
Just to define one term, NCD means non-communicable diseases, right?
Non-communicable diseases.
Until very recently, like I think the first person to get chemotherapy for cancer treatment in Kono received treatment last year, right? Methotrexate got to its first patient last year. Is that right?
Yeah. But like, I think also like at the Catholic hospital that I was working, they were treating bucket lymphomas. That was only there was a bucket lymphoma program there that they were treating kids with lymphoma. But like, it's a private hospital. It's a Catholic hospital that had link with a Spanish hospital in Barcelona that were sending us those drugs. I was running that cancer unit when I was at Lone Star St. John of God Hospital. But like, apart from that, there was no government facility treating cancers, and so Kono started that also. And now I think at the referral hospital, the children's hospital, they can also treat bucket lymphomas and another cancer. But like, you have to buy the drugs. That's the most important thing. So, whereas at KGH, we're able to provide those drugs for free.
Yeah, and that's really critical because like healthcare that can't be afforded isn't healthcare, right? Like, I mean, if you can't afford it, you can't get it, and that doesn't work as a system. But other non-communicable diseases like hypertension and type 1 diabetes, all of these things were never to very rarely treated, and now we're starting to see at least them being treated in some cases, which I think is encouraging. And the other thing is just to kind of give people a visual. I mean, this doesn't really work geographically, but you can almost imagine like the hospital KGH as like the center of a wheel or the center of a hub. And that's in Koidu, which is a city of about 150,000 people. And then Wellbody is a primary care center. And there are other similar primary care centers around the district, but only Wellbody is good. Is that safe to say? Like, the reason Wellbody sees hundreds and hundreds of patients a day is because it's the only place that you can really get consistent, good care.
I can safely say and confidently say Wellbody Clinic is the best clinic in the country, in the entire country. And it's seen the highest number of patients in the whole country. And so when you think about So you have let me talk about this in two or three perspectives, right? When you want to say, okay, I want to see the HIV testing increase, like the indicator for the Global Fund. You want to see TB testing increase. Like, well, Body Clinic is a typical example that shows that, because, like, if you can see 300 patients, you can test at least 200 patients from those people. But, like, if you have a clinic that sees 5 patients a day, 2 patients a day, how would you reach the targets of like testing many people? You reach many people on treatment. So it's like, we talk all these indicators. Oh, you need to test this number of people, you need to put this number of people on treatment, but there's no investment in the primary healthcare. And that is what I see I saw as a dilemma with, like, this big donors like uh Global Fund, other people. They don't want to invest in primary healthcare. They don't want to invest strongly in what drives patients to the facilities, but they want to get more patients. And you can't get more patients if the quality of care you're providing in those facilities is not great. You cannot get, if you're seeing 150 patients a month, how many of those can you test for HIV? How many of those can you put on treatment? Whereas, like, at Well Body, you're seeing thousands a month. You can test. So that's why you find out that in Kono, Well Body is only comparable to KGH, with the number of HIV patients that they see, with the number of TB patients that they treat. Because, like, you have a lot, because the quality of care is driving a lot of people coming to the facility, you can then have you can have access to many patients that you can cancel and put and test for HIV, test for TB, put them on treatment, put them on care. Same for hypertension, diabetes. Like, when you are in a facility, you don't have a blood pressure machine, cuff, you don't have a glucometer. How would you test for blood sugar? How would you test for blood pressure? You will not. But, like, when you have all those things, that's why I'm saying, investing in those facilities and putting more equipment and medications or whatever, you can then drive the healthcare rapidly in this country. Because, like, you go to these facilities, they don't even have a scale to weigh a patient. They don't even have a
kids
thermometer.
a lot of times, so they don't know if there's no way to know if kids are underweight. There's no nutrition programs if kids are underweight. Like, it's and I think this gets to something that's really essential, which was really important for me to understand when I began learning from you and your colleagues. This idea that I had, that you come in with a solution, like a vertical solution, like, oh, there's trouble getting pregnant women who need emergency C-sections from the clinic or from their home to the hospital, so you buy an ambulance. That's a simple solution, and it's so good narratively. Like, if you're raising money, that's such a great, easy narrative. Like, buy an ambulance, pay this much money, and you'll buy an ambulance, and but it doesn't work if there's no parts for the ambulance. It doesn't work if the ambulance breaks down, breaks an axle on a road, and then the ambulance is just like sitting as a piece of furniture in front of the clinic for the next 30 years. This idea that I had, that it's either this or this, it's either X or that's all wrong. It's and it's primary health. You have to have primary health care, and you have to have secondary and tertiary health care. You have to have community health workers going out into communities, visiting with individual patients, checking in with them to make sure that they have the ability and resources that they need to take their HIV medication or their TB medication. And you need to have a primary healthcare clinic where they can go and they can get tested for things and find out if they have hypertension and anything else that anybody else would expect from primary healthcare. And you need a hospital where the clinicians can refer complicated cases to. All of this has to happen simultaneously. And if you just do one thing, it will be a very nice narrative, but it won't make any lasting change. And that's what we are working to, like, find a way to try to tell that story, which is less narratively compelling. Like, it's kind of harder for fundraising, to be honest with you, but it's the truth, at least as we've learned it from you and your colleagues.
Exactly. I mean, I think it's a difficult thing to raise money for, but it's the right thing to raise money for. So, for example, I'll give a typical example when they said when UNICEF said, okay, we need to get women to the facilities, and like, oh, you don't have cell phones in those facilities, so we put a radio on in the facilities so that they'll be able to call. But then they call, but where's the ambulance? Where's the fear that takes this woman from that point A to point B where she can receive care? So like you put these radios, that's why you go to many facilities, you see radios there, but like they're broken, they're not working, they're collecting dust. And like thinking comprehensively and thinking like holistically is what is difficult to fundraise for, but is the right thing. Like you said, it's not this or this, it's this, like community healthcare workers to visit people, patients in their homes, educate them about HIV, educate them about prevention. But when they're sick, they're able to go to this facility, and then they were able to screen properly and test their pressure, test their sugar, blood sugar, test their hemoglobin, on all those things. And then you're able to make a diagnosis and say, okay, this patient get this, I cannot treat this patient, I'll send him to KGH. And so there's a mechanism to take this patient from point A to point B to point C, so that the patients can receive care. But if you say, oh, well, we're unable to get patients to the facility because, like, for example, because there's user fee in the facilities, so we just remove user fee. But then we don't improve the quality of care. Still, women don't come to the facilities because the quality is weak, is poor. There's a lot of healthcare workers that are not going to the facilities. Women come, they don't see them. So it's like you have to say, okay, we want to make sure that patients come to the facility, the patient receive the high quality care that the patient deserves, and then you have to put all those things, all those pieces in place to have a robust healthcare system. And that is what is lacking actually in many, it's not only in Sierra Leone, in many low middle income countries, that you have donors that come and say, oh, I just want to invest in maternal and child health, period. I want to invest in HIV. I want to invest in TB. But I think about the holistic health system. A TB patient needs his pressure to be, you can have a TB patient with both hypertension and TB. Or HIV patient with both hypertension, diabetes, and TB. But like he will not receive care, he will just receive the HIV care and don't have and is unable to receive the TB or HIV or hypertension or diabetes care. So the diabetes will kill him instead of the HIV. So it's like you have to consider these things in a holistic way, in a comprehensive way, to have a functional healthcare system. And I think that's what Partners in Health is trying to do. You have to get the right amount of staff in the facility. You have to get the right amount, the basic equipment. You have to get the basic medications in the healthcare facility, so that the facility will be able to see patients and treat them, and they don't need to go to hospital.
Well, Dr. Barrie, I think we have to leave it there. I think we've taken enough of your time today. It's always so great to talk with you. It's always so encouraging, and we really appreciate you taking the time to talk with us today. And we look forward to working together to support you and your colleagues as you build out that robust healthcare system over the next several years. Yeah, we'll talk soon again, I hope. But in the meantime, thank you.
Thank you so much. Thank you so much, John. Thank you.
No, it's always